All right, good afternoon, everybody. We're going to get started. Welcome. Thank you all for coming. I'm Rob Ehrman. We're from Wayne State at Dr. Sullivan and Mark Favot. We're going to talk about speckle tracking echocardiography is the sort of next frontier in echocardiography research. So a few quick thank yous. Philips for setting us up with this machine and being extremely flexible and making it all happen at the last second. Thanks to AUS for sponsoring this didactic, and thanks to you guys for coming. You're at the tip of the spear because this is really the most exciting aspect of echocardiography currently. So what we're going to do is you're going to get a brief introduction to speckle tracking, then you're going to get a live demo with Dr. Favot and Dr. Harrison here, and then I'll come back and talk about some of the research applications. So I'm going to turn it over to Dr. Sullivan.
All right. Can you guys all hear me okay? Great. Well, as Rob said, my name is Ashley Sullivan, and I am one of the Associate Ultrasound Fellowship Directors out of Wayne State University and Ascension St. John Hospital in Detroit, Michigan. And it is a pleasure to be here with you guys talking about a topic that has really become of increasing interest to our group in the past several years. I'm going to begin with a brief introduction and a little primer on strain echocardiography. And really, we're going to actually start with concepts such as deformation and strain rate. And I'm hopefully going to show you how we can use those concepts to evaluate and understand cardiac function. And finally, we're going to move in and I'll actually introduce you to the actual use of strain echocardiography and the speckle tracking software that makes it all possible. But before that, let's take a little detour. This is Tommy Rivers. And as you can see, Tommy is a runner. Actually, to call Tommy a runner is a bit of a mischaracterization. You see, Tommy is a world-class athlete. He's an endurance runner, he's an ultramarathoner, and he actually has some fairly impressive accomplishments under his belt. Tommy just recently completed the Boston Marathon, and he did so in a little over 2 hours and 23 minutes, which is an impressive feat by anyone's standards. In the lead up to the Boston Marathon, Tommy did quite a bit of training, and one of the runs that he would frequently revisit was the one that you see right here, a route that took him up Lake Mary Road just outside of Flagstaff, Arizona. And it's a brutal run. It goes up nearly 15 miles, over 7,000 feet of elevation. And on this particular day, he was actually running with one of his longtime running partners. He was running at about a pace of 5 minutes and 50 seconds. Again, pretty impressive. But as he would later say about the moment captured in this photo, sometimes things are not as they appear. This is me getting dropped on Lake Mary Road. You see, Tommy struggled quite a bit that day. While he was able to complete the training run, it wouldn't be before he was basically passed by his longtime running partner, Stephanie Bruce. You see, Stephanie is an equally accomplished runner in her own right. She just completed the New York Marathon, and she did it in a little over 2 hours and 30 minutes. So what was the difference between Tommy and Stephanie that day? They both completed an impressive run. They did the same mileage, put down the same mileage, but they did it at a slightly different pace. Slightly different overall time. And we understand, even if we're not runners, that it's not as simple as just telling Tommy to run faster or try harder, right? We understand that running mechanics are complex, and they rely on detail that is often granular in nature. So what if we approach the performance of the heart in a similar manner? What if we could actually start to move beyond traditional parameters of ventricular function to a more granular and detailed approach, one that takes us, in fact, down to the level of the cardiac myocyte? What if that technology existed now? Technology that was able to give us this granular approach to myocardial mechanics. Would you use it? Would you put it into practice? The road to strain echocardiography dates back nearly half a century, when we really started to first understand the importance of evaluating myocardial mechanics and, more importantly, myocardial motion. And in our attempt to understand myocardial motion, we actually first turned to the past, to a technology that most all of us have come into contact with in our practice, Doppler. Now, we're familiar with using Doppler echo to determine the velocity and direction of moving blood, but we can actually apply the Doppler technique to evaluating the lower velocity, high intensity signals from myocardial motion. In other words, we've been able to shift the target from the red blood cell to the myocardium itself. And in doing so, we've gotten a small window into global and regional myocardial function. And this understanding led to the development of tissue Doppler. And it was an early step in the echo assessment of cardiac mechanics. And over time, the technique evolved, and we were able to use tissue Doppler imaging to essentially assess myocardial motion at one point relative to another. And our goal was simple. We wanted to analyze regional motion. But there are some complications with looking at tissue Doppler imaging, concepts of translational motion and tethering. With translational motion, you can see here that if you had the sample volume placed in this basal segment, but the whole heart is moving within the chest wall, well, there's going to be velocity associated with that motion, but it may not actually represent true contraction. What about tethering? Again, imagine that if you have the sample volume placed in this basal segment, and let's say that that basal segment is akinetic. Well, you have surrounding segments that are still going to pull and tug that akinetic segment with it, and in doing so, you're going to get some velocity, but are we really getting true contraction? So to overcome these pitfalls, we began to look beyond just tissue velocity, and we started to look at more local parameters, such as myocardial deformation. But what is deformation? And how do we measure it? And before we can answer these questions, it is important that you guys understand that the concept of deformation is at the very foundation of understanding strain echocardiography. And thankfully, deformation is relatively easy to understand because we see it in everyday life. Deformation is simply just the change in size of an object due to an applied force. And some types of deformation are permanent, like plastic deformation, much like this car, right? The car, as it strikes the wall, it deforms, and it's unlikely to ever return to its original shape. The type of deformation that we're interested in, though, is elastic deformation. And it's happening continuously in our cardiac and our myocytes as we're basically going through contraction and relaxation. And obviously, it's not limited to skeletal muscle. We see this in cardiac muscle, where it started to give us this more detailed view of myocardial function. Specifically, detail that shows us whether supposed normal, healthy myocardium can actually deform or shorten appropriately during contraction. Well, what if we could measure or quantify this deformation in some way? Quantify how much one region of the myocardium is deforming compared to another. And the answer takes us out of the realm of medicine, and it takes us into the world of physics, where, simply put, strain is just simply a unitless measure of deformation. And it's represented by a single equation, which you see at the bottom here, and we often express it as a percentage. And again, this concept is also simple. Imagine you have an object. Let's say that object is originally in length 8 centimeters, and we apply a force, and in this case, that force is a weight. Well, that object will deform to a longer length, let's say 10 centimeters. And when we lessen that force or remove that weight, it will revert back to its original length. And we can actually calculate that change in length, again, expressing it as a percentage by using this strain equation. In this case, using these kind of numbers as an example, our strain would be positive 25%. When we talk about myocardial strain, though, we're really just describing the elastic properties or elastic deformation of cardiac muscle. And of course, we rely on the same equation. But unlike the previous example where we saw positive strain, deformation of normal, healthy cardiac muscle often results in negative strain. And that's because during contraction, the myocardial fibers are going to deform to a shorter length before they revert back to their original longer length. And in this case, again, using these numbers, our strain would be negative 20%. Additionally, we can also represent strain as the rate of deformation, which we call strain rate. But strain doesn't occur in just one direction. Strain is a dimensionless index of myocardial deformation. And so we can define it as a vector acting in multiple different directions. And this is important because the left ventricular myocardium undergoes a complex multidimensional deformation throughout the cardiac cycle: radial, circumferential, longitudinal. And thankfully, we can measure strain in all of these directions. And this is important because this complex myocardial deformation is brought about by an equally complex arrangement of myofibers within the left ventricular wall. Fibers that are arranged in a helical orientation with both clockwise and counterclockwise movement, almost creating a ringing-like effect during ventricular systole, the whole goal of which is to maximize the efficiency during contraction. And of these fibers, it's the subendocardial fibers of the heart, the ones that are oriented in a basically parallel to the long axis of the ventricle, that predominantly determine longitudinal contraction or longitudinal strain. And unfortunately, as most cardiac pathologies involve the subendocardial fibers, longitudinal strain is also usually the earliest to be impaired. And so while we can measure circumferential and radial strain, you can quickly see why we give much emphasis to longitudinal strain. We've discussed concepts of deformation. We've talked about strain, briefly touched on strain rate. But how do we take these theoretical concepts and how do we move them to the bedside? And the answer lies with the development of strain echocardiography. Unlike conventional techniques of determining systolic function that rely on a visual assessment of wall motion and volume assessment, strain echocardiography actually measures tissue deformation in the myocardium itself. And it relies on unique acoustic fingerprints, or speckles. And these speckles are generated by interactions between the ultrasound beam and myocardial tissue. And they're identified within a defined region of interest. And then we can track them frame to frame throughout the cardiac cycle, the distance between them giving us quite a bit of information about what's happening with both regional and segmental myocardial deformation. Speckle tracking, though, is a recent development, an image processing that uses software to automatically determine the movements of these speckles within the myocardium over time. And all of this strain echocardiography, speckle tracking, it all begins with simple grayscale imaging. If we want to measure the longitudinal strain, we have to obtain clips of an apical 4-chamber, an apical 2-chamber, and an apical long axis. And once acquired, they're saved, and we'll come back to them to essentially trace the endocardial border using speckle tracking software. The software is going to help us to delineate the endocardium, the myocardium, and the epicardium, and it assigns speckle regions of interest within the myocardium of each segment. These speckles, again, then are tracked frame to frame. The left ventricle then is taken, and it's broken up into 18 segments where we can calculate systolic strain for each segment. That segmental data, which you can see here, superimposed on this apical long axis, is then combined to give us a global evaluation of myocardial strain, which we call global longitudinal peak systolic strain. And in healthy individuals, this is between -18 and -20%. Once we calculate it, we can depict our strain data in quite a few ways. Here you can see 4 different images. In the top left, you see essentially the parametric regional strain map in that apical long axis view. In the top right, you have the strain curve. In the bottom right, we have what's called the bullseye plot. And finally, the bottom left shows the color in mode plot. And we're going to actually begin with the bullseye plot, which, as I mentioned before, is one of the ways that we can represent strain and gives us quite a bit of information. But first, you can see the bullseye plot is actually made up of several rings. The outermost ring representing the basal segments, the middle ring representing your mid-wall segments, and that very inner ring representing your apical segments. Second, the plot is going to highlight for us our global longitudinal strain, which we have derived from our segmental data, and you can see it right here denoted kind of in the bottom right-hand corner. And finally, the plot is going to provide us with almost a red and blue color coding legend. And it serves as a nice reminder that in longitudinal strain, blue basically represents positive strain or lengthening, and red is representing negative strain or shortening. It's also important to understand that during systole, you're going to see shortening with both longitudinal and circumferential strain, but the opposite applies with radial, where we see thickening, and it's going to be denoted as positive strain in that case. In the case of this bullseye plot here, we can actually see impaired longitudinal strain in this basal inferior kind of wall. And this was a patient who had an indeterminate troponin and actually went on to have a non-ST elevated MI. Now compare that to this bullseye plot here. This is a patient with cardiac amyloidosis. And you can see quite a big difference in the color coding on the plot when you compare it to the previous image. Here, the apex, which you can see in the center of the plot, appears to basically have relatively preserved strain. And we denote that essentially kind of as that red coloring. And you can see in contrast to the rest of the bullseye plot, which looks fairly abnormal. These strain maps initially seem a little bit complicated, especially if you're not used to it. But over time, you can quickly begin to see patterns emerging between normal and abnormal. We don't need to look at just the bullseye plot. We can actually also represent our strain data as a simple linear graph, with each segment of the left ventricle essentially being represented by a colored line, where x-axis is time and y is strain. And since the myocardium usually shortens in a longitudinal direction during systole, the longitudinal strain and strain rate curves are displayed actually below this baseline. Well, what are some of the advantages to strain? It's not angle dependent, so unlike tissue velocity imaging, which is, it relies on grayscale imaging, and it's going to let us evaluate strain in more than one dimension. And it's semi-automated, so the software is going to do some of the work for you. And last, we can also assess rotation, which we get from circumferential strain. But like anything, there are limitations. Strain really requires good image quality. It requires high frame rates, and it's important to understand that there are inter-vendor differences between the software. So we've gone over concepts of deformation, strain, and strain rate, and hopefully I've shown you how strain echocardiography is going to bring those concepts to life. And in a minute, we're going to do the how-to, but I want to leave you essentially with the why. Why do we use strain echocardiography? And the clinical applications have started to become widespread and impressive. We've already seen that strain plays a role in acute coronary events. Again, this patient who had strain changes and went on to have a non-ST elevated MI. But strain actually can be a predictor of our final infarct size. It can show us the patency of an infarct-related artery, and it helps give us outcome data after revascularization. Strain also helps with the detection of subclinical myocardial dysfunction, such that we see in patients undergoing cancer chemotherapy who experience cardiotoxicity. And beyond that, strain can act as a surrogate for EF. It plays a role in cardiac resynchronization. It tells us quite about left ventricular diastolic function, as well as assessing right ventricular function. Helps us to differentiate LVH etiology. The possibilities really start to seem endless. And if I haven't convinced you already, then I'll simply leave you with this, that if you're not using strain, you're missing out. And with that, we're going to move on to our live demonstration.
Hi, I'm Mark Favot. I'm at Wayne State University in Detroit. I work out at Sinai Grace Hospital. You're going to be seeing the back of my head for most of this, I think, so I thought I would introduce myself and say hi. I'm going to be at the machine. I'm going to do a 15-minute kind of live demo. I'm going to try to focus on some elements of image acquisition that are really critical. There's a lot of small little idiosyncratic things that if you don't get them right, it turns into a bit of a garbage out, garbage in, garbage out type of situation. And then I'm going to go through an analysis with you, talk about a lot about the waveforms. People who are, who's familiar with strain before today, like familiarity, maybe heard of it. You've probably seen a bullseye map. It makes for a really nice picture in a journal or in a tweet or whatever you're going to use to talk about it. But really a lot of the meat of this is in the curves. The curves really let you know how each segment of the heart is doing over time. So without further ado, I'm going to scan our voluntold model, Dr. Harrison. And I think from here forward in the presentation, we're really going to focus on only longitudinal strain. As Dr. Sullivan said, the subendocardial fibers are the most sensitive in the heart. So most of the applications of strain have really focused on longitudinal strain, and most of the vendor packages have longitudinal strain on board the system. So that's really where all the money here is in longitudinal strain. And if you were privy to the text messages between Rob and I that went through all the things necessary to get this equipment here, you'd be truly appreciative of his efforts, as I am, so thank you. So we're going to start with an apical 4-chamber image. You should be able to see on the screen here, the people in the front row can probably see straight on the machine. Do you want to roll toward me, Nick? So the apical imaging is where all this is at. Let's say you go back home, you have a machine, you're like, what? That stinks. I don't even have strain on the machine, so what's the point? Eventually you will, and the best way to make use of it is become really good at imaging all three of the apical imaging windows. So I'm going to talk a little bit about tips and tricks you can do to get better at imaging these sometimes difficult windows. So one of the keys here is that we want to maximize the chamber, the endocardial border definition, and it doesn't matter if things are centered. Ashley mentioned how Doppler strain is like really angle dependent. So if I had an angle like this for a Doppler-based modality, it would be unacceptable, right? I'm gonna roll a little more, Nick. But if I end up, I'm in a critical care type situation, and I have a patient who I can't get better images than, let's say, my angle, I'm gonna try to create an angle here that is like 30 degrees. If that's all I got, I can still do speckle tracking. My Doppler data is gonna be invalid at that angle. But if all I have is that 30 degree side tilt angle, and you've gotten that in some patients before, I do, I'll admit it. Sometimes that's all you got. Well, strain, we'll use the temporary ID. Strain is angle independent. It's probably one of the key features. We'll take another clip. What we've done with our research is we tell people, if you think you got it on the first clip, take about 3 or 4. Because sometimes if someone will throw a PVC, I don't know if you guys are paying any attention to the ECG tracing at the bottom, but when you do strain, you do have to give it a little more attention than you probably do. Most of your machines have it, and you're probably not using it during clinical scanning, I imagine. I wasn't until I started doing strain. But you always got to pay attention. If they throw a PVC in there, if the heart rate changes by more than 15 beats a minute between segments, it's not going to be very useful. The second imaging window I'm going to go through here is the apical 2 chamber. This is probably one that is underutilized in like the point of care world, in my opinion. And the reason so is because it's really hard. I'm going to show you how hard it is here in a second. In fact, I think I'm showing you unintentionally right now how hard it is. So that's his aorta. If you can see his aorta at the bottom of the screen, that typically means you're a little high. So if you look, the chamber looks nice, it's pretty, but I'm very high. The ventricle should have a bit of a bullet shape at this point. So if you can see the apex of the LV is off to like the top left side right there. And so if the chamber looks too long and narrow or too rounded, or if you start seeing this guy, the RV, you're under-rotated. So you want to be fully rotated. We have our friend here called the Coumadin ridge. Right here, you see this little white line. People call that the Coumadin ridge because people will confuse it for an LA thrombus. That's a really good marker that your apical 2 chamber is on axis, that you're lined up, that you're looking at the true anterior wall to the right and the true inferior wall to the left. If you think of the apex of the LV like a cone, and you're basically going from a 4-chamber to a 2-chamber, if you haven't spun the probe such that you're lined up with the anterior wall, you'll get strain data, but it's not actually the anterior wall. It's some amalgam of the lateral wall and the anterior wall. It might be anterolateral. So you really pay attention to your little cues, and one of them is that little Coumadin ridge in the LA. It's a good indicator that you're rotated properly. So I'll go back and get the image. I think I saved a clip, but I just want to save one more. So that's, when you go back to do an apical, start with your 4 and then rotate into a 2. And the 2 ends up being about a 90-degree rotation. And see, this is very classic. See the inferior wall on the left really nicely? And the anterior wall is just shadowed out with air. The fix here is to have your patient take a shallow breath and hold it. And he took too deep of a breath and everything went away. So now I'm going to have him take a shallow breath and hold it. Actually, you can, right there, take a little, there, stop. That's not the best, but I'll clip it. And it's really important to know if your machines are doing retrospective or prospective. I would recommend to set it for retrospective when you're doing strain, because you never know if someone's going to throw a PVC or something when you hit the prospective, or if your ECG cable is going to fall off. So if you're going to do strain, I would strongly recommend you set retrospective clips, 3 beats or 6 seconds. But retrospective is best, because you know what you saw, you don't know what you don't know what you haven't seen. So again, when you go back to re-image him, you start with the 4. We're going to rotate into a 2. Take a shallow breath. No, that's poor imaging by me. So there's my RV friend, so that means I'm too anterior. So I'm going to slide my probe, take a shallow breath. More, stop. Too much. All right. And then we go to apical long axis, which should look like a parasternal long axis image, but turned on its side. And I'm just fighting for it here a little bit. I'm going to drop my depth a little bit, which is going to increase my frame rate. Remember, if you're doing LV strain, you can sacrifice the left atrium. So when you're doing like an echo and you're not doing strain, you obviously don't want to chop off the atria. But if you're just doing LV strain and you really want to maximize frame rate, and I would recommend you want frame rates higher than 40. Here we have a frame rate of 53. And if you really want to maximize frame rate, you can just say bye-bye to the left atrium. This is pretty good right here, so we'll clip it. Oops. Don't breathe. And this is an image where you want to play with end expiratory hold. Obviously, you don't tell your patient do an end expiratory hold. What I tell them to do is take a deep breath, as deep as they can, blow all the air out, and then don't take another breath until I tell them to. And then you just have to remember to tell them to breathe. Or when their heart rate gets down to 20. That can be a reminder to tell them to breathe. All right, and I'm going to just reclip the two, and then we'll go through the curves, okay? I was not happy with my original two. If you're seeing an aortic valve like this, you're too high. So to see there's the aortic valve, we're too high. So you want to get low, and that's great. Shallow breath. Hold. Okay. Your participation in the events of today is over, Nick. So what we're going to do next is I'm just going to show you how to run through a strain analysis. I'm going to make it take a little extra long just for teaching purposes. In general, it's about a 2-minute process. You spend about a minute on the first one, and it takes about 30 seconds to do each of the other two, especially if your images are good. So, I want my pointer. 5 minutes. Thanks. So we're going to go to... How do I get the AC and Q up here again?
So you're going to want to, don't do that.
Oh, close.
So you want to go to his images, remember? So hit the pointer.
Okay. Oh, and just highlight.
Highlight them.
Okay.
So whichever
Got it.
ones you want.
Okay.
Let's give a hand for our model, Dr. Harrison. Thank you.
Yeah, I'm going to do this one.
Giving his body to science.
Oh, perfect. Thank you.
So you want to pick your 3 images. It's obviously helpful if you can remember which ones are your best ones, but we on the 12. And then I had some good longs somewhere in there.
So just double click on
Click on the number, and then
You want to double click on it?
double click.
Real quick.
Yeah, that's good.
There you go. Move the 4 up.
Okay, cool. And then the feature on the Philips package is called ACMQ, so you're going to hit that button. Each vendor has their own name for stuff, so obviously when you buy this stuff or start using it, you'll become familiar with the names. So we're going to start with the, I actually only have 2 loops in here. Close QApps. I just got to highlight this one, that's our 2. Then I need a 4. Can I choose one from over here? Right? Okay. So here's our 4. We're going to start with our long, or I think Ashley might have used the word 3-chamber. 3-chamber is long. They're the same thing. That's our 2. This looks like our long. So we'll call this LV apical 3. So the reason you start with the 3 or the long is because the machine wants to know when the aortic valve closes to mark systole. So you can see the aortic valve in your 3 chamber or your long, which is why you start with that. It's asking me to enter the aortic valve closure time, but it actually has it marked right here on the ECG tracing. So I should just be able to draw this. One of the keys with the anchor points is that the LVOT is not part of the ventricle. So one of the pitfalls people will make is they'll put this anchor point here, that one right there, they'll put it too deep into the LVOT, and they're actually getting non-ventricular tissue there. So that tissue there in the LVOT doesn't actually deform. So that will give you an inappropriately low strain rating. If you see a tracing on the software and it looks reasonable, like if I could nitpick this, I would fix quite a few things here. But remember, it has an algorithm, and the algorithm's kind of smart, and it's probably smarter than you at running its own features. So if it looks reasonable, just let it do it and see what kind of data it gives you. So that's what I'm going to do. In a perfect world, I would adjust some of these, but I think this is just fine. So we're going to do compute. There's a little blue bar you might not be able to see at the bottom left. It takes about 5 seconds to run the algorithm. And so here it's giving you the data. The one segment it doesn't like is this basal inferolateral segment. So if you look, it's the one that's all the way up here. So this is failing the quality check. This segment is not being tracked adequately. So what we would want to do, in the interest of time I will not, what we want to do is just retrace it. You just put the anchor points back on it. I think what I would do is actually smooth it out and increase the width of the sector, so I can just quickly show you how to do that. So I'm going to put this anchor point a little bit down here. I'm going to put this one up here. I'm going to put this one right here. And then what I'm going to do is I'm actually going to make it a little wider. So what I noticed when I was scanning Nick earlier is that like the default sector width is a little thinner than his myocardium actually is. So what you can do is you can just drag this. I mean, you can make it, you know, like your cardiac amyloidosis type situation. You can make it very large. What you want to do is you want to have it big enough to capture all the myocardium and not the pericardium, and to exclude all the noise, all that lung noise, all that tissue or air artifact. You want to exclude it. This looks a little bit better to my eye. Again, this is something you just got to play with. You got to get your machine, get like a medical student, get a healthy subject, and play with it. You're going to get super frustrated with the machine the first 5 or 6 times you play with it, because there's a lot of little idiosyncratic features that you'll just run into that you just never thought were relevant before, like the heart rate variability, PVCs, a little bit dropping out from the lateral wall sector width. All of these little issues that, like in the grand world of point-of-care ultrasound, don't really matter. They matter a lot when it comes to something that's semi-automated, where you have to kind of set everything up, and then the program can run its thing. So this looks much better. We're going to go on to the next one. We'll go loop 1, which I believe is our apical 4. So loop 1's apical 4. We're going to draw it, put our anchor points on, bam. Bam. Remember, the mitral valve annulus is actually part of the ventricle anatomically. So if it looks like I put those anchor points a little deeper than maybe you thought the LV is, well, the mitral valve annulus is a left ventricular structure. So that is where it goes. This sector width is actually, I could probably kick it out just a titch, and then I'll compute it. The better your images are, the more likely, when you put the anchor points on, that the system is just going to draw it perfectly every time. So here we go. This is pretty normal looking. This is a nice gentle base to apex gradient. Normal hearts have a base to apex gradient, meaning they have more shortening in the apex than they do in the base. I'm going to accept it. I'm going to do the last one, and then Rob is going to wow you with the research applications of Speckle tracking. Oh, I already did that one. This is our LV apical 2. We'll place the anchor points. So I happened to pick one where I didn't have the basal anterior image very well, so you can see it doesn't even know what it's looking for. So I'm going to have to do some serious editing here. But in the interest of time, I'm not going to edit it too severely. We'll just leave it like that for now, and then we'll compute it. So you can see this is like pretty nicely depicted. Because I picked the apical 2 that wasn't the greatest, if you look at the basal anterior and the mid anterior, it ain't seeing much. If there's no speckles there to track, it ain't going to track very much. But we'll accept this. Trust me, Nick, you did not have an apical infarct today. But if you did, you're in the right place. You know what we're doing. And then we're going to go. I may have to accept them all. I accepted that one. I accepted this one. And here's our results. So it gives you the bullseye. Just like Ashley said, outer ring basal, mid ring mid wall, inner ring apical. So think of it like a cone, and you're looking from the top of the cone kind of down around the cone. That's how it's depicted. For help, they tell you which walls are what. The last thing that's really neat that Rob's going to talk about, so I'm just going to team up a little bit, is this concept of time to peak strain. So not only can you actually measure how much deformation happens in each segment of the ventricle, you could really assess when it happens. So a healthy, happy heart is one where all of the segments are doing the same thing at the same time, right? If my anterior wall is shortening, I want my inferior wall to shorten at the same time. And if one wall is lengthening while the other wall is shortening, that's a really inefficient use of oxygen and ATP. And this will get depicted in this. So that number inside each segment is the number of milliseconds it takes for that segment to reach peak deformation. And you want them all to be clustered around the same value, ideally right before aortic valve closure. When ventricular segments lengthen at that time or shorten much later than that, it's a really inefficient use of oxygen for the heart. I'm going to leave it at that. I'm going to pass it over to Dr. Ehrman. He's going to talk about the research applications of strain that we're studying.
All right, thank you, Dr. Favot. Anybody who has echo questions, direct them to Dr. Favot. He's the local echo expert. I've learned a ton from him. All right, so I'm going to talk to you. I'm Rob Ehrman. Hello again. Thank you for coming. I'm going to talk to you about the research applications of speckle tracking echo. So quick review. Remember, we're using 2D images to identify speckles, acoustic signatures within the myocardium. We call those speckles, and then we track those throughout the cardiac cycle. We use that data to glean information about cardiac function. Now, this is a great idea, right? But it's not enough to just have a great idea. We have to know whether or not it actually does anything meaningful for our patients, and so that's where the research aspect comes in. And if we're rigorous and we do it well and we have a little bit of luck, we actually have some positive results and we improve patient care and outcomes. And if we're really lucky, the way the research process is supposed to work, it's iterative, and it just becomes this self-fulfilling or self-sustaining cycle. Unfortunately, most of the time, it doesn't work out, but that's sort of kind of life in research. But one of the things that I think we can do to maximize the chances that we're going to have success, not just with this application, but with all research applications, is to be open and honest and sort of address our limitations as we design our projects. And so with speckle tracking, there are some technical limitations. We can kind of divide these roughly into the patient-related and then the technologically related issues. On the technological side, right, there's inter-vendor differences. Every manufacturer's strain software produces different numbers. There's issues with image quality, as you saw with Dr. Favot. There's issues with where you trace the endocardium if your region of interest is appropriately defined. And then on the patient side, remember that for most echo parameters, there are age and gender-specific normal values, but at this point, there are no such values exist for strain. And then there's all the things that we do to patients, right? We give them fluids, we give them positive pressure ventilation, inotropes, vasopressors. All of these things are going to change the strain values that we measure, and that's going to affect our research data. Now, there's a lot of clinical and both research applications that exist with speckle tracking echo. Not all of them are going to be applicable to emergency medicine. Where I think we really are kind of poised to take the lead on this is with heart failure, with ischemic heart disease, and also with some diseases that are not primarily cardiac and etiology, thinking about pulmonary hypertension, PE, and then the area that I'm interested in my research is focused on is sepsis. So starting to move forward, talking about ischemic heart disease. So what we're really thinking about, right, we see a patient, they come in with chest pain. It looks like they've got some inferior ischemia. The next step is to think about the coronary artery perfusion distribution, right? And the next thing we do when we're talking about echo is look for regional wall motion abnormalities that correspond with the area that we think is ischemic based on the EKG. Now, obviously, we're not talking about STEMI patients here, right? We're thinking more about the subtle patients that come in with some chest pain. Maybe there's some subtle elevations inferiorly or depressions in AVL. You put the probe on the chest, you see, well, maybe there's some hypokinesis in sort of the apical portion of the septum. Maybe this portion has a wraparound, maybe this patient has a wraparound LAD with a distal occlusion. But you can see that it's subtle, right? And so the question becomes, how good are we at identifying wall motion abnormalities in 2D echo? And the answer is we're actually not all that good. Now, most of this comes from the cardiology literature because this is where it's been studied most extensively. This was a study where they took patients that had 2D echoes, then went on to get angiography, and they asked a bunch of cardiologists to look at the echoes and decide whether they thought they had 1, 2, or 3 vessel CAD or no CAD. You can see here when it's 3 vessel CAD, they're pretty accurate identifying it, right? There's kind of global hypokinesis. That's not super subtle. But with 1 vessel CAD, the agreement rate between cardiologists was only 60%, so that's actually pretty poor. And even with no CAD, it was only 80%. This is a really cool study where they they used computer simulations to create wall motion abnormalities. And in various segments of the myocardium, they showed it, I think this was with 6 cardiologists, and they asked them to identify the number of segments that were hypokinetic. Down here, this is sort of the limit of detection by the human eye that's thought to be clinically meaningful. And you see with these really subtle wall motion abnormalities, there's not a lot of agreement, right? It's not till the abnormalities or become much, much more evident that everybody is identifying them all the time. So 2D echo for regional wall motion abnormalities is probably not super great. And hopefully you can start to see through what you've already heard why speckle tracking is actually probably going to be a much better way to identify this. So this is an apical 4-chamber view. This is the lateral wall. This is the septal wall. And you can see that the septal segments are contracting in a very organized way. They're peaking at about the same time. But when you look at the lateral segments, you see it's much more disorganized. These little boxes represent the peak strain. And they're peaking at different times. Some of them are actually after aortic valve closure. This is the coronary artery perfusion distribution projected onto that bullseye map. And this is that patient's bullseye tracing. So you can see there's some posterior lateral impairment and strain. This patient actually went on to, or was found to have a total occlusion of the intermediate artery. So they've studied this. They really love this technology in Europe. This was a study where they had patients with NSTEMI who got 2D echoes, then went on to get cath, and what they were looking to try to determine was how predictive was strain versus 2D wall motion abnormalities for identifying complete coronary occlusions. This curve up here is the strain parameter, so it did pretty well, certainly a lot better than the 2D parameters. Now, neither one of these is great, but strain is clearly better. Now, this all looks very promising, but the truth is not every study has found such sort of differentiation between 2D findings and the strain findings. So there's still a lot to be done. There are also a lot of limitations and unknowns that we should consider as we sort of move forward with this technology and the research. The most important one, I think, is the chronicity of the findings. So obviously the implications for acute wall motion abnormalities versus chronic wall motion abnormalities are markedly different, right? One's going to go to cath and one is just, medical management, whatever. Close behind that is, even if we identify these patients early and we get them to cath, does it make any difference for patients? Now, we all get a patient at the cath lab and we high five and we feel good about ourselves, but it's far from proven that actually that doing that actually leads to any improvement in outcomes either in the short or the long term. Ultimately, this is an area that has not really been studied very much, and there's actually both good aspects and bad aspects to that, right? When there's not a lot of data out there, there's an opportunity for us to define the landscape, right? To do the studies, to kind of be the pioneers. On the flip side, when there's not a lot of data out there and it's sort of unproven, everybody is going to be far more skeptical, more likely to poke holes in your studies and your ideas. I think generally it's more positive, right? This is somewhere where we really have the potential to take the lead, but keep in mind it's not all supportive and positive data. So when we move into the kind of heart failure world, in chronic heart failure, it's pretty well established that impairment and strain, both in the LV and the RV, is associated with worse long-term outcomes. In the acute heart failure realm, the landscape is not quite as well defined. We know that patients who show up with cardiogenic shock have a worse prognosis. We know that if your troponin is elevated, even if it's not from an acute occlusion, that those patients have a worse prognosis. Hopefully, we all know that BNP is dead for acute heart failure for the most part. But the role for echo is not quite as clearly defined. Now, historically, emergency physicians, we've kind of used it as a diagnostic test, right? Impaired systolic function, yes or no, is a way to help us determine if a patient's presentation for dyspnea is related to heart failure. And that's important, but it hasn't really changed much in the last 10 years. Now, this was a study where they looked at patients who were admitted for acute heart failure, and they got their echoes a few days into their admission, and patients with impaired strain had much worse long-term outcomes, and it was a better prognostic indicator than EF. But this is a 5-year timeline, right? We're not quite as interested in this. So as we start to think about where we can go with echo, with research, what are we going to do differently with it? On the one hand, it hasn't changed a whole lot how we use it in emergency medicine, but it's not unique to echo, right? Treatments for heart failure have not changed a whole lot in the last 20 or 30 years. Some of the medications have different names, but it's basically the same concepts. Lung ultrasound has been hugely influential, but it's still kind of on the diagnostic side, right? We're looking to see, is there pulmonary edema, yes or no? And it answers that question for us very well, but it doesn't tell us why. And so where echo, and specifically strain echo, I think is going to help sort of change the landscape is it's going to answer that why question. It's going to give us information about what the heart is doing. We're going to see patients when they arrive. We're going to get an echo. We're going to start to treat them. We're going to get a second echo, and we're going to see how they've progressed, and we're going to use that longitudinal information to decide what we're going to do next. So everybody knows and talks a lot about ejection fraction, and so I just want to briefly tell you why EF is not the variable we should be studying for this. The first reason is it doesn't change a whole lot over the course of treatment. This is a study where they had patients admitted for acute heart failure. Their EF here on the y-axis in the acute pulmonary edema phase, and then over here on the x-axis is in the resolution phase 1 to 3 days later. And what you can see is despite the fact that their systolic pressure decreased by about 25%, the EF remained relatively constant. The other thing that's important to understand about ejection fraction is that it's not a functional measure of LV performance, it's a volumetric measure. And more than that, it's a relative volumetric measure. So this patient on the left has an impaired LV ejection fraction compared to this patient who has a supranormal ejection fraction. But if you actually start to look at the hemodynamic data, you can see that the patient on the left, despite having a markedly impaired EF, has a relatively normal cardiac output in comparison to the other patient whose EF is more than double the first patient but has a subnormal cardiac output. But it's not enough to just say, well, EF kind of stinks. We need to understand why strain is potentially better. So again, here's another patient who's got heart failure. You can see that their ejection fraction is impaired, but it's not really till you look at the bullseye map that you get a really granular understanding of what's happening in this LV, right? So this kind of anterior lateral wall is not really doing a whole lot, and in fact, it's actually lengthening during systole. But we're not just using that as a single time point. We're thinking about this more in a longitudinal fashion. We're going to scan this patient when they show up. We're going to treat them. Then we're going to see what happens to their LV on a segment-by-segment basis, and then we're going to use that information to guide subsequent treatment steps. This is data from a study that our group just published, led by Dr. Favot. So we had patients with acute heart failure who got an echo at time 0 when they arrived, and then 23 hours later, and we looked at 30-day readmission rates. So you can see that everybody had reduced ejection fraction and everybody had impaired strain. The patients that didn't have a readmission at 30 days actually had a much greater relative improvement in their strain compared to those patients that did have a 30-day readmission. And more interesting, I think, is this idea of mechanical dispersion. And so really how you can sort of conceptually think about this is it's a way to measure the overall sort of synchronization of contraction of all of the LV segments. So this is a normal strain tracing from the apical four-chamber view. You see all of the different segments, they're contracting fairly uniformly, they're peaking about at the same time. It's all in dark red, so we say, okay, yeah, this is good. And it's easy to see the difference between this tracing where there's just a ton of disorganization. What all of these arrows and these numbers represent is the time to peak strain in milliseconds for each segment. And so what mechanical dispersion index is the standard deviation of the time to peak strain. So if you have all of your fibers contracting in a very organized fashion, there's not going to be a lot of variability. Your MDI is going to be low. Whereas in this patient, where the peaks are all over the place, your MDI is going to be much larger. And you can kind of see conceptually how this might relate to outcomes and how patients are going to do. If you imagine a patient who has a fixed mass of functional myocardium, right? They're going to get the best forward flow if all of those fibers are contracting synchronously, right? Contrast that to a patient like this where it's just disorganized and it's all over the place. And so this patient's going to have worse forward flow. There's going to be more pulmonary congestion. They may in fact be more symptomatic. And our data, kind of supports this general hypothesis, right? Because the patients that had 30-day readmissions that had worse outcomes, their MDI actually got worse at 24 hours. They were more disorganized. Compared to the patients that didn't have a 30-day readmission, their MDI actually improved. So what this suggests perhaps is that the ventricles of these patients were not adequately unloaded. Now, they may have felt better. They may have been a little bit decongested. If you did a lung ultrasound, you may have found fewer B lines. But this is why I brought up the idea of lung ultrasound telling us the yes, no, not the why. And this is really something, this is the advantage of speckle tracking echo. Obviously, this is all very preliminary data. It needs to be studied more, but I think it's really promising and exciting. So in wrapping up, I hope that we've convinced you that speckle tracking echo is really the future of echocardiography research. I think it's going to be something where we can really take the lead. We're uniquely positioned because we see patients when they show up at the door before treatment and nobody else has that. And it's surprising when in all of these applications almost nobody nobody takes advantage of that aspect and nobody has the ability to like we do. But there are obstacles, right? We're going to need buy-in in collaboration with our ICU colleagues, our cardiology colleagues. It's not enough to just, see a patient, get some echo data, do some treatments, and then kind of wash our hands of it, right? We're thinking about using this in a longitudinal fashion. We see the patient, we gather the echo data, we see what their LV is doing, we treat them, we do another echo, and then we see how their LV function has changed, and we use that information to kind of determine what comes next. So we're not only handing off the patients to our inpatient colleagues, right? We're handing off that data too, and they have to know what to do with it and how to take advantage of it. And so that's where the collaboration comes in. Feasibility issues, right? We certainly recognize that not everybody can do speckle tracking. We certainly don't think that everybody should run out and try to do it, but what we should do is study it rigorously in order to determine whether or not it actually benefits our patients, because if it does, then we have a lot of power to go back and use that to actually get speckle tracking into more EDs. Now, again, these are real obstacles, but I think they're surmountable. They can put a CAT scan machine in the back of an ambulance and drive around and get you your TPA 17 seconds earlier. And if they can do that, we can get speckle tracking into our EDs. So with that, we're going to wrap up, and then we'll take any questions that you guys have. That's the end. Thank you for your attention. I'm going to let them handle the questions. I have to run to moderate an abstract session. So thank
In
you
the
guys,
back?
and thank you again to Phillips.
Yes.
Great job. Thanks so much, guys. I was wondering, actually, with your study, these are sick patients that are coming in, and you saw just on a healthy model how hard it was to get all of these through names. Did you do a quality score, or was there
So, yeah, really good question. Even in really sick patients who have good images, it can be a challenge when they have a lot of respiratory distress. A high respiratory rate, high minute ventilation, and a high heart rate can limit it. So we found in our study, so the first time we published, we actually did that. We had like an inter-rater reliability and a quality score. What we did was we scored the tissue border or the blood tissue definition. We had an independent cardiologist look at it, give it a 1, 2, or 3. And then we had the tracking system will actually give you a check mark or an X if it feels it's adequately tracking the segment. So we looked between the two users on the same set of people, how often you got like 18 out of 18 checks, 15 out of 18 checks. And so what we found was about 12% of 10 to 12% of patients, it just is not going to work. Whether it's because they're too tachycardic or their windows are just too difficult, like that's your base rate. Like if you talk about your acute heart failure population, just toss out, and in reality, probably more like 12 to 15%, they're out. But the rest of them, like we found, in our studies, we've only had to really toss about 10 to 15% of patients because of an inability to do the data analysis, which is about half of it is quality. So half of it will be like that anterior wall. Like I just chose the wrong anterior wall segment. If I had chosen a better one, it would have been fine, but it was instructive. So half of them that we toss, so of the 10 to 12%, half of them will be for quality. And it's usually the anterior wall, or it's usually the lateral wall because of the lung. And then the other half, it's because of some technical ridiculousness. Like they just had a bunch of PVCs, or one thing that will happen is the heart rate for the long axis was 60, the heart rate for the apical 4 was 60, the heart rate for the 2-chamber was 89. And there's too much variability in the heart rate for the algorithm to put together a bullseye, because the number of frames it was able to analyze for that clip where the rate was 89 is roughly half of what it was able to analyze for the clips where the heart rate was 60. So that's kind of what we found. Good question. It's about 10, I would say probably 15% is your base rate. It's not going to work. Yeah, in front.
How well does this work if they have like AFib?
So if they're controlled AFib, what you end up with AFib is your R to R variability is all over the place, right? So you'll have like an R to R length here, 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 here. So if they're AFib and controlled, we throw them out. We don't do it in AFib. That's an exclusion criteria. If you're actively in AFib, it's an exclusion criteria to our heart failure research for this. But what you can do is you can actually just run the algorithm 5 consecutive times. Because over the course, and that's generally like in cardiology and echo research, when someone's in AFib, they just do it like 3 more times. Like if they normally run Simpsons once, they'll do it 3 times if it's an AFib because of the variability of the R to R interval. With the assumption being that if you do it in enough contractions, your mean will represent the mean R to R interval. All right, thanks everyone. Thanks for coming.